Okay. Good afternoon to everybody, at least the people who are on the European sides of the world, and good morning to Dr. Jackie Saw, and who is in Vancouver. So today, first of all, my name is Christian Vincent. I'm very glad to welcome all of you in this session. So FEops is very dedicated to contribute to the education into the PCR 2021. And the session will be to optimize the Abbott Amulet LAAo preoperative planning using FEops HEARTguide. So today, it's my privilege and my honor to welcome the faculty, Dr. Jackie Saw. Jackie Saw is from Vancouver General Hospital, University of the British Columbia, Vancouver in Canada. So this will be in this Zoom session. It will be 30 minutes, including discussion. So you will see there is a chat line at the bottom of your screen. So please use that for any interaction, ask any questions. I will consolidate all those questions and asking those questions to Dr. Jackie Saw at a certain moment of the presentation. And of course, Dr. Saw will try at least to answer all your questions. So the methodology of the day will be a case-based discussion. So it's really case-based. And it will be as interactive as possible. You will see that there will be also some quick polls where you will be able to answer a couple of questions. I wish to all of you a very nice presentation, and I'm stopping sharing, and Dr. Jackie Saw can start sharing her presentation. Thank you.
Great, thank you very much, Christian. Thank you for having me. Thank you for the team to have me here on your PCR satellite session. And it's my pleasure to show you a couple of cases this morning on how I utilize the FEops software on a day-to-day sort of LAA closure procedures. And I'll show you two cases. And as Christian mentioned, please just forward your questions in the chat box, and I'll be happy to answer that at the end of the talk. And I'll try and make sure the slides presentation will be finished, giving us about 10 minutes for discussion. So this is the first case. As with all my LAA closure procedures, I would do a baseline CT for pre-planning. And typically I would utilize the Vitreous software. So this is an example showing a cactus configuration left atrial appendage. And you can see that we may be a bit challenged in terms of depth for this particular appendage. And this is during the time when we were still utilizing the Watchman 2.5 generation device and also Amulet. And so you can see the measurements that were obtained at the ostium of the left atrial appendage. It measures between 26 by 17. And so we were considering using a 31 millimeter Watchman 2.5 device. So this procedure actually initially was done in a different hospital, and I was the proctoring physician. You can see the cactus configuration here in a baseline TEE. Especially in the 135 view, you can see the tuberculations actually might be protruding and impacting on how we implant the device. And the osteal measurements here on TEE were a bit smaller than the CT, which is not surprising, right? We have up to 23 millimeters in measurements, whereas on CT we measured up to 26 millimeters. So when they attempted the procedure, they used an RF to gain access to transeptal puncture. And you can see the Watchman double curve sheath and a pigtail inside that, and they're injecting into the upper lobe of this appendage. And I'll show you a couple more images here. You see that the appendage actually looks pretty large, and also there's not a lot of depth. So with the puncture that they obtain, I think it might have been a little bit high, and there is challenge in terms of trying to counterclock and get up more coaxial. And they've decided that they don't want to actually pursue further in terms of risk for perforation. And this is one of the earlier cases. So they actually aborted the procedure at that time. So maybe I'll ask the first polling question. And so what to do next? Should you go ahead and attempt a Watchman device still? Or would you change over to an Amulet implant? Or would you redo the transeptal puncture? Or would you just abandon the procedure altogether? So Christian, maybe just start the polling here. And if you want to cut my slides to go to your polling results, please go ahead. Should we do that other poll? do my question first, or should we go into your poll? I'm flexible.
Can you see the poll, Jackie? And
yes, I can see your polling, but do you want people
yeah,
to
yeah.
answer my questions? I guess it really doesn't matter. Well, we can jump straight into your poll because I already said that, we attempted to change over to Amulet, but I'll show that later. But why don't we go to your poll? So your poll number one is, would you consider, so considering that we're switching over to Amulet here, so the poll disappeared. Oh, there it is. We already have the answers. So the question was, would you consider using computer simulation as a preoperative planning tool? And so what we have is 42% of the audience here says, yes, I was informed about it, but never used it. Okay. And 33% actually split, said, yes, I already have experienced it, and half of them, I don't have information about it. So that's interesting. That's good to know that there are, a bunch of novice participants here, and they'll be happy to show you what FEops can do in these couple of cases. All right. So I'll close the polling question. I'll move on to my next slide. So what we did was decided to switch over to Amulet. And knowing that this was a challenging procedure that was aborted in a different institution, I wanted to have as much information as possible. Yes, we had the CT information, but I wanted to see, what the computer simulation would do in terms of predicting what, where to implant, what size of the amulet, it would recommend, and also where the implant is. So this is the sort of baseline imaging. You can see that, yeah, we see this cactus configuration again, and the markers here, the green being the landing zone and the blue being the osteal zone. That's where the measurements are given. It's kind of cut off in that slide. But more importantly, I wanted to show what FEops software simulation showed in terms of what devices and what size and location. So this is a 25 amulet simulation with proximal implantation. So what you're seeing here is red, that means there is no contact. White is when there's contact. So we got some contact here, but not a lot of contact with the lobe. And obviously we want good apposition to make sure that the device is stable. So this is an Amulet 25 proximal implant. So if you place it distally, you can see, okay, sort of doing a half sandwich technique here. And you have the white part that's in contact, red's not in contact because it's a half sandwich technique. But you can see that the disc is actually pretty well opposed to the ostium of the appendage. So this is actually not bad. And then there are other sizes that were simulated. So this is a 28 amulet proximal position. I must say that I don't like the proximal position. You can see that that actually ends up protruding out a little bit more, and the disc may not be covering the ostium very well. So I don't like that, but 28 distal actually looks pretty good. And again, this is somewhat of a half sandwich technique. And you can see for the most part, the lobe is well opposed in terms of the white areas. And you can see even the disc gets pulled in with a fair bit of white, meaning it's pulled against tension, against tissue contact. So that's a good thing. So 28 distal looks pretty good. And even 31 potentially could be utilized here with distal positioning. So there are a few choices. My thoughts would be, my first choice would be a 28, and then we'll see where it fit. So that's what we did here. So this is procedure at our hospital. So I used a VersaCross to gain access through the transeptal and aiming for pretty inferiorly. But I think, the first time round, I wasn't happy with that. So you can see that with the TorqueView 45 degree sheath, with that transeptal puncture, I was still having trouble actually getting access into the appendage with a pigtail catheter. So I actually redid the transeptal puncture. So this poor patient now actually had 3 transeptal punctures, so the third one. So I went lower for sure, and definitely posterior. But I would say that, doing transeptal is so straightforward and easy with the VersaCross. So I would, drop up a hat if you can't rotate your sheath properly to get access in the appendage. I would just do another puncture very readily. So here is a more inferior positioning, and here is just showing the VersaCross loop wire acting as a rail for me to advance the TorqueView sheath into position. And here I just want to show you side by side. So the right side is the new transeptal puncture, where I'm showing you that the TorqueView is now more coaxial to get access to the superior portion of this appendage, whereas on the left side, it was a slightly higher puncture. So I was being forced more horizontally, and it's hard to really properly deploy the device. So I went for a 28 device, and so this is showing the ball being pushed out more into the lobe configuration. And because there's not a ton of depth, I really have to be very slow in my deployment and deliberate in terms of trying to keep the lobe in position. And you can see that when it comes out, it's actually very well opposed. So here is a picture in, on the TEE showing that it's not bad, it's compressed against one of the lobes. But there's a little gap here. So the question is, would the disc uncover the orifice entirely such that we're not worried about that little gap? And so here I'm just showing you the disc coming out. And so this is essentially also a tension test already. And you can see that the disc position actually looks pretty good. And I don't really see much of a gap for this appendage. So here on the left panel is me doing a tension test. As you know, we don't do a standard tug test for these Amulet devices. We do a tension test, pulling the disc back and holding for about a minute in terms of tension to make sure that the lobe does not move. And it actually did not migrate at all. And so the picture on the right side is just taking a cine angiogram after the tension test. And you see that the device has remained in position. And here on TEE, you can see, we go through the 4 angles to look at if there's any gap. We did color flow in 4 angles. And even though there is that gap in the lobe, the disc actually covered that. So it looks very good. So here we release the device and you can see the final shot here. The disc actually popped back in a little bit here. And then so I repositioned that. So the final shot here actually looks pretty good. And this is well positioned and the 3D imaging looks really good. So I was happy with the position. And after having, a failed Watchman attempt, obviously the patient's very happy that we can implant an amulet for him. So we're 10 minutes in, I'm going to go into the second case presentation and I'll leave time for discussion. So this case number 2 is a 67-year-old woman with paroxysmal AFib chest VAS score of 3, had ruptured, MCA aneurysm that resulted in a spontaneous subarachnoid hemorrhage a couple of years ago, and also has a residual aneurysm in the left posterior cerebral artery. So he's not a candidate, or she's not a candidate for long-term antithrombotic therapy. So this case we did as a recording for the Abbott team, and I utilized a different CT software. So we do have co-registration in our brand new cath lab, and we have the GE workstation. So here is me manipulating live, essentially, the GE workstation. So you can see on the left panel is typically what I would do. I would manipulate the oblique multiplanar reformat images and basically go measure the ostium of the appendage in biplane in sort of, oblique, multi-oblique planes, coaxial planes. And then I would look at the 3D. Here, as you can see, this appendage, again, is I'm choosing all these cactus configurations because they can be actually quite challenging. So this is a cactus configuration with multiple lobes that that I was, not as happy with using a single lobe device where we might miss the ostium. So I wanted to have a disc, which is why we chose Amulet for this implant. So here again, I'm showing the FEops software, so this is the sort of baseline image. You can see the measurements. The landing zone maximum diameter was measured at 21 millimeter, and the minimum diameter is about 18. So you can see the proximal trabeculation. And so the question is, how would the devices fit? Because of that proximal trabeculation, if we use a large device, it may not actually be able to expand against that proximal pectinate muscle. So there was I have some concerns about that. So these are the different simulations that FEops did. So that's 20 millimeter, which I thought was perhaps undersized here. And this is 22 proximal. You can see this obviously protrudes a little bit more with the disc not covering the edge here. And so that wasn't ideal. And there's a gap. So this is 22 distal. And again, you see as a computer simulating that pectinate ridge might be a problem for the lobe that might prevent it from fully expanding. And but I'm happy with the disc sort of position. There might be a small gap, but I think there's a lot of apposition with the lobe of this device in this configuration. So that actually looks good. Now this is 25 millimeter, which I thought was a bit too big because you have a lot of protrusion of the lobe. And so now then the disc actually can't come in to cover that portion that's protruding. So It might be doable, but you know, I was concerned about it being a little bit too oversized. And so I decided that I think, you know, the 22 distal probably is the best configuration for this anatomy. And obviously, you know, we have to do the procedure to see how the tissues respond to the compression by the device. I'm using the phone as a timer, so I'm making sure that I'm not doing double time. So I'm letting this video just run. This is the full-length video. And then the next slide actually here will show you that there's also, you can also look at this image from a frame deformation perspective, which is also a nice rendition of the simulation. But I find the other one actually more useful. So the plan is to actually go in with a 22 amulet device in this distal position. Okay, so that's the pre-planning. So this is the procedure itself. We're fortunate we were able to record, so I was able to show you some of these live images together with the TE images and the floor images. So this one is me shaping the VersaCross sheath. And the nice thing with the VersaCross sheath, the dilator is shapeable. So if you have a big right atrium or left atrium, you can shape it to whatever shape you need to, so you can get proper tenting. So here we've introduced the VersaCross loop wire into the SVC, and this is the VersaCross sheath, transeptal sheath in the SVC. And here I pull back the VersaCross inside the VersaCross sheath, and then we will pull the whole system down. So as we pull down to do the transeptal puncture, I'm just letting the video run here. As we pull into the fossa ovalis, I didn't show the tent actually, that was in the other video. That's fine, it's not as relevant. So here we have a good tent, and then so once we're happy, we apply energy to get the RF wire across. And then, you know, it's a straightforward exchange wire. Essentially, the VersaCross is an 035 system, a very stable, supportive wire. So we basically exchange out to the, this is a 12 French torque view, 45 degree sheath. And so it just slides over the transeptal puncture very easily. So once we have that across, we just remove the VersaCross wire and a dilator slowly, so we don't entrain air. And I typically will make sure that the sheath is below the level of the heart, so we're not getting air being suctioned into the sheath for sure. And you want to make sure there's back bleed here, just showing that there is blood bleeding back from the sheath. And then the next part is to just connect and get your pigtail in position. And here we're highlighting that, you know, we have co-registration. So this is CT that's co-registered with the fluoro images. You can see on the right panel here. And so we formatted the 3D image of the left atrium. You can see the appendage. So you can see that, you know, my pigtail is getting into the appendage. I don't even need to inject during this procedure to know that my pigtail is already in the appendage. And then I just slide in the sheath accordingly to get it into the appendage, right? So we're using the pigtail to navigate us into the appendage. So once we're in, then here's taking a couple of shots. So this is the areocaudal projection. So we can see the shape of the appendage as what we predicted on the CT and the software simulation. It's the, you know, cactus configuration. You can see on TE as well, this early proximal branch. And then here's another view. Usually for amulet implants, I also want to do a areocranial projection here. This is just another projection here. And just let it play a little bit here, just showing the image. Okay, so that's just another projection, okay? And so the plan is here to advance a 22 millimeter device. And actually that was a different areocaudal projection. So this is the areocranial projection here. And so the areocranial projection for amulet is usually useful for deployment of the disc, whereas the lobe I tend to deploy in the areocaudal projection. So here we prep our 22 millimeter device and we've advanced it up into position. So we're ready to deploy this now. So the first step is a withdrawal of the sheath so I can get into the ball configuration with the amulet. And so I do this step, you know, slowly. You can see my left hand on the sheath, and my right hand actually on the cable, pushing the cable in, whereas my left hand is pulling back the sheath, right? So the end result is a withdrawal of the sheath and showing the ball. So with the TE, you can see where the ball configuration, where the ball is at. And also with fusion imaging, you can see where the ball is. So I'd certainly have room to advance the system in before I deploy the rest of the load, okay? So here is me showing that I'm rotating counterclock and advancing the ball farther in before deploying it. And then when I'm deploying it, it's actually a very, very slow deployment of the ball because you want to have the lobe expand slowly and for the hooks to capture the appendage as it comes out. So I like the ball and the lobe deployment very slowly, so it avoids it from jumping back. So you can see that when the lobe is entirely out, it's actually very much compressed in a tire configuration here. So the next step here, let's see what I did. So here I'm injecting contrast to make sure that I'm within entirely, and it actually looks pretty good. Okay, there is a tiny gap here in the proximal part, and so we're going to go and deploy the disc next. So here's the disc coming out, and let's just see. So the question is, will the disc be adequate to cover that gap as well, like the other case? And so we have the disc out here, and you can see that the lobe actually didn't move when I'm deploying the disc. So here I'm injecting contrast to see. And so I think in this case, you can see, you know, there might be a little gap here inferiorly, and that, you know, maybe, you know, that's sort of what we predicted a bit on the FEops software. So the question is there color flow through that little gap? And actually on TEE, on color flow Doppler, I think there's a good image coming up where it shows that we did have a little color flow. And I'll just show you another image of that. Yeah, you see that little zap of color going across here towards the end, right there. Okay. And so here's another image here. You can see that little gap, the disc is not entirely touching. And now with color, that's a nice mega view of that. You can see that color, little color jet over here. So I wasn't entirely happy. I mean, I suspect that this, if I've left this will probably close up on its own, but I decided that I would just reposition this. So then what we did was just do essentially a recapture. So recapture the disc in, recapture the lobe in, and into the back of the ball configuration. And then you can see I counterclock and re-advance the whole system in a little bit deeper and just redeploy, okay? And so here I'm just redeploying, and there's a whole recording here. So I'll just let it run and show that. And so here is the lobe slowly being advanced out. So one other trick is you see my left hand is actually not advanced towards the groin to control the sheath really well. So I'm really keeping the counterclock with my left hand, while my right hand is pushing out the lobe entirely, okay? So here I'm happy with that position here. Now we're taking another cine picture and then deploying the disc. I didn't show it the cine picture with the lobe. So here I get the disc out. You can see that the lobe is already actually deeper than the first position. And so with TEE now, that little gap is no longer present, okay? And so just show you multiple, and we even have 3D TEE to show you that the disc is well opposed. So if you look at the 5 signs of amulet implants, it was achieved in this case. You have separation between the lobe and the disc, the tire chip configuration of the lobe, the concavity of the disc, the coaxiality of the lobe, and on TE, the lobe is within the circumflex artery by at least half or 2/3. So, and you can see on the fusion imaging that, you know, that is a good positioning, and on cine angiogram, it also looks very good. I'll just fast forward towards the end here. So this is another view. This is the RE cranial projection, again, showing that the disc is well opposed and there was no gap. So after we release the device, this is just showing counterclocking and releasing the cable from the disc itself. And so you can see the device popping into position well after the release, and just taking a final shot here to show that everything looks well opposed and TE images look good. Okay, so here is just another example showing, you know, challenging case with FEops simulation prior. So here's our poll number 2. You can go ahead and show the question, please. So after the session of my experience, would you consider using computer simulation? Yes for all the cases, yes for selected cases, or I need to investigate more. Please go ahead and make your selection. Okay, do you want to show the results? There it is. Wonderful. So now we've convinced a number of people. So we've got 55% saying yes for selected cases. And even a third says yes for all cases. Well, that's wonderful. And so 9% are the skeptics. You know, I need to investigate more. But all in all, I think, Christian, you should be very happy with these polling results, right? So we can close the polling. And I think we have about 5 minutes or less remaining. Christian, you can tell me how much time we have for discussion. I'm happy to answer any questions that you have that's popped up in the Q&A. Close this polling.
Yeah. So first of all, thank you so much, Dr. Saw, for this amazing presentation. I really like the comprehensive way you are presenting this new preoperative tool, but into the flow of your preoperative planning into your hospital. There are at least one interesting question coming from the audience. Does FEops provide the software a kind of overlay in the real-time imaging during the procedure, and if so, which software is used for that?
Yeah, so it's a different software that we're using, and so when we built this brand new cath lab, which is a hybrid OR basically for us to do the structural procedures, we have the GE install the fusion imaging for CT. They also have fusion imaging for echo as well, which we'll explore. But so for the CT, we basically have routine CT baseline imaging for all our patients, you know, standard protocol that we use for LAA protocol and EP protocol. So that's usually imaging the atria during diastole. And then we upload that into the GE workstation. And so basically, when we put the patient on the table, we'll take some fluoro images to co-register with a CT. And then you have that live view during the procedure. So it's not something that FEops provide necessarily. The FEops provide the simulation before we do the procedure. But you know, I think that's a good question, whether you can overlay the FEops simulation on top of what we're seeing live. That could be interesting. I'm not sure if that's possible though. I mean, Christian, maybe you can answer that.
Yes, sure. And thank you for your answer, Jackie. Indeed, we do have a lot of projects together with the imaging companies. For example, we have that with the major companies. You just mentioned one example of GE. We also have some example with Philips and other providers. And indeed, we are working for the preoperative planning, but we're also working on the perioperative intervention with the fusion images. So we do that today, and we are still a bit in the development of that, on those possibilities, but it's clearly a direction that we are taking into consideration for the future. Another question, Dr. Saw, is that I saw in the poll number 2 that first of all the people, and I'm of course very glad to read that, are aiming to use the simulation for the future. I see that 55% of the people were voting for selected kind of patients. Can you comment a little bit on that? What would be your recommendation on the selection type, on the type of morphologies, different anatomies, or what would be your personal recommendations?
Right, yeah. So I've been using CT for many, many years for pre-planning for LA, and it's routinely done for all my patients unless the GFR is really low. So CT, I think, is definitely, you know, I think critical for most procedures. And from the CT baseline itself, you can see what other challenging anatomies. And I would say that, you know, certain chicken wing bends are more concerning, especially those that are retroflex bend towards the right or very short depth before it makes the bend. So these retroflex chicken wing is certainly one challenging anatomy. The other ones are those with early bifurcations where you're challenged with the depth before the bifurcation, or early trabeculations, like some of these two cases that I've shown, these cactus configuration one. So I think there are anatomies, if you're concerned about the particular device that you're using, so it might be, say, Watchman Flex. you might not have access to Amulet, depending on where you are. Obviously, in the US right now, you only have the Flex device or the old generation 2.5. And so having simulations will help you decide, how deep you want to place, or would you have to be proximal enough to cover these proximal interveculations? So I think definitely at a minimum, using FEops for selective cases are very helpful. If you have the ability to have FEops for every single case, well, that's wonderful. But I think where most institutions will be challenged with the cost of doing so.
Yeah. Okay. Thank you for those recommendations. I cannot agree more with that, and that's exactly the experience we do have so far. So time is running, so I want to conclude here by saying a big thank you for Dr. Saw for this very, very impressive presentation as usual. And to the audience, also thank you for your attendance, and please consider to visit us on the website. We can always offer you some free test of the FEops HEARTguide. That's always the best way to discover all the potential of this new possibility for you. And in the meantime, I wish to all of you a very nice PCR 2021. Thank you, Jackie.
Great. Thank you very much, Christian. Thanks, everyone. Have a good day. Bye-bye.
Have a good day. Bye-bye.